So we are good to start. Shall we begin?
Yeah.
All right. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. And he is none other than Dr. Nagarjuna Yarlagadda, sir. It's my pleasure and honor to introduce sir at our platform. He's a very renowned gastroenterologist. Sir is MD, GM in gastroenterology, Chief Consultant Gastroenterologist at Sunshine Hospital, Hyderabad. With the help of sir, we'll be taking a close look on today's topic, which is management of irritable bowel syndrome. Before moving on to today's session, let us have a brief look on what the topic says. Irritable bowel syndrome is a highly prevalent chronic disorder of the gastrointestinal tract that significantly reduces patients' quality of life. Management of IBS includes lifestyle changes, medicines, probiotics, and mental health therapies, such as cognitive behavior therapy, relaxation therapy, etc. We'll be knowing more about the topic with the help of sir. And now, without taking much time and without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his talk to begin. Sir, over to you.
Yeah, sure. So, I speak from the help of iPad. So I believe you can see only one screen, either my slides or me. So I think already I loaded my slides. So yeah, I think you'll not be able to see me. Are you able to see me, Nishita? Hello? Are you able to see me?
Yes, sir, you are visible, sir. Your slides are not moving.
Okay, great. Are you able to see me? I thought only slides can be seen. I don't know. Okay. So IBS is a condition which is more of a functional bowel disorder. And this is very common in our country. And not only in our country, all over the world, this is a disease which is very prevalent and affecting a lot of people. And also, there's a lot of wastage of man hours. That means working hours are lost because of the IBS problem. In this today lecture, I'll be talking overall about what is IBS and what are the types which we talk about in IBS category and how do we diagnose, and also a few points about the pathogenesis and also treatment point of view. Well, it's a functional bowel disorder, and usually it is more of abdominal pain or discomfort, and which is related to the defecation. That means let's say abdominal pain with relief of pain after passing a motion, something like that, and also the change in the bowel habits. That can be the number of motions or the type of motion, the consistency of the motion. If you look at the prevalence and demography, and the left side is Western countries, right side is India studies. The prevalence is a little more in the Western countries. In India, it's about 8% in India, up to 20% in the Western countries. But I feel it will be a little more than this. But then whatever data is available at this point of time, in India, around 8% of people suffer from the IBS. That's a huge number. And in West, it's mostly more in the females compared to men. But in our country, it's more in the men than the females. And the age group is usually younger age group. And the clinical features wise, in the Western population, the IBS is more of a discomfort of the lower abdomen. And in our country, the predominance of upper abdominal symptoms are more. Well, how do you diagnose? There's simple criteria. And generally, this goes in the name of Rome 1, 2, 3, 4, right? Latest is Rome 4 criteria. In the Rome 4 criteria, the criteria is very simple. To make a diagnosis of IBS, you don't require much of investigations. This is more of a recurrent abdominal pain, on average, at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria. That means the last 3 months, once a week, if you're suffering with abdominal pain, with some relation to the defecation, that means that the pain usually decreases after passing motion. Sometimes it can go a little, it can get aggravated. And also, this discomfort or abdominal pain there's an association with the change in the frequency of the stool. Again, I'll tell you, I'll show you, I'm going to show you a stool chart about the stool consistency, and also associated with the change in the form of stool. That means consistency. That is relation to the defecation, stool frequency, and also the stool consistency. Well, the criteria fulfilled for the last 3 months with symptom onset at least 6 months before diagnosis. That means the patient should have these kind of symptoms at least for the last 6 months. Well, before you make a diagnosis of IBS, IBS is a irritable bowel syndrome. Usually it is more of a functional bowel disease, and usually it won't lead to any major issue. But then, before you jump on the diagnosis of IBS, it's important for you to look at the red flag signs. Red flag signs means stop there and investigate. If somebody is more than 50 years old, and also recent change in the bowel habit, particularly in the 50 plus age group, and also evidence of clear-cut GI bleeding, that can be blood in the motion or melena or black motion. So that automatically rules out IBS, and you need to look for a organic cause for the GI symptoms. Well, in the IBS, generally night pain or night motions are not a part of IBS. So if somebody has a pain in the night or passing stools in the night, nocturnal diarrhea, they need to get investigated. And also, with an unintentional weight loss, somebody is obese or somebody is trying to lose weight, that's a different issue. If somebody is losing weight, that means you need to look for the reason for the weight loss. So it's no more IBS. In IBS, you don't lose weight. And also, there's a family history of CA colon or inflammatory bowel disease, that's ulcerative colitis or Crohn's. You need to rule out those conditions before you jump onto a diagnosis of IBS. Well, on examination, if you find a mass per abdomen or lymphadenopathy, a patient requires further evaluation to rule out other causes. Important thing is iron deficiency anemia is very common in our country. That is not a sign of IBS. If IBS, if somebody has a anemia, particularly iron deficiency anemia, that means the patient is losing some blood to the GI tract. So they need further evaluation for the iron deficiency anemia. And also, routine fecal occult blood test positive. That means blood is seen in the fecal matter is no more IBS. Well, I was talking to you about the stool chart. So very simple thing. Those is only for a pictorial drawing, which I'm showing you. The top one, type 1 to type 7 types are there. And the top 2 are more of constipation type, where the motion is hard. In type 1, separate hard lumps, or it can be sausage-shaped but lumpy. That is more of constipation type. And type 3, like a sausage bug with cracks in the surface. Type 4, like a sausage or snake with smooth and soft. Well, the last type 7 is a watery stool. So, and type 6 is a fluffy pieces with ragged edges and a mushy stool. So this is a Bristol chart which helps you to allocate to the constipation type or diarrhea type. In between, like in this case, top 1, 2 are constipation type. Last 2 are 6 and 7 are diarrhea type, IBS-D and IBS-C. Between the type 3, 4, and 5 is more of a mixed variety. Well, the IBS patients, generally they go mostly to the general physicians or MUS doctors, and then they go to primary care consultants. Very few come to the super specialist, that is gastroenterologist. But then, in our country, by and large, we see all kinds of these patients in other specialties. But definitely, these patients are more often they end up seeing the GPs, general physicians. Well, if you look at the pathogens of IBS, there are many: genetic predisposition, and then environmental factors, change in GI motility, alterations in the gut microbiota flora. All these things are there, including psychological symptoms, and also immune system dysfunction. All these things can be part of IBS. When you don't have a clear diagnosis, like let's say tuberculosis, you get the tuberculosis because of a bacterium or malaria. This one is the reason for the malaria. But in case of disease like irritable bowel syndrome, we don't have a clear diagnosis. That's why various things are proposed, both as a cause of IBS and also in the pathogens of IBS. Well, one is brain gut axis alteration, intestinal motility, visceral hypersensitivity. And like visceral hypersensitivity is more of, let's say, suppose somebody has a small amount of gas in the small intestine, and in some people, they feel it's much more uncomfortable. The same small amount of gas in the small intestine, particularly if they're stuck into a segment of small intestine. And there's a difference or some discomfort, some dissociation in the central pain processing that also is part of IBS. And also most important is intestinal microbial dysbiosis or small intestine SIBO. SIBO is small intestinal bacterial overgrowth. That also can be it can be reason for the IBS. Well, if you talk about SIBO, this is a clinical syndrome of GI symptoms caused by the presence of excessive numbers of bacteria within the small intestine. And generally, the colony count is usually around 10 to 3 in colony per ml. And to make a diagnosis, mostly we take 10 to the power of 5 in duodenal or jejunal aspirate. And the same count is much more in the colon or in the ileum. And if you look at the bacteria, there's more of coliforms, including gram-negative, aerobic, and anaerobic bacteria. And some people are more prone for SIBO. That is, when somebody has a abnormality in the small intestine, such abnormalities, or there's dysmotility is there in the small intestine or colon, then they can have IBS symptoms also. Other population at risk, one is the SIBO. Other population, the risk is of small intestinal bacterial overgrowth. One is IBS category, organ dysfunction, metabolic disorders, elderly, and also people who take a lot of antibiotics. There's a dysbiosis in the GI tract causing this overgrowth of few type of bacteria causing SIBO, and excessive use of PPI, that is proton pump inhibitors. We are the culprits for that. And a lot of our patients, we do prescribe PPIs that also can cause development of excessive bacterial overgrowth in some of the small intestine. Well, I know this slide is a little crowded and you'll not be able to see much of it. In this, what I'm trying to show is in duodenum, the colony counts are lesser. Look at the colon, 10 to the power of 11 to 10 to the power of 12 CV per ml. And again, the type of bacterial change in duodenum and stomach. Stomach, you see streptococcus and staphylococcus is there, and lactobacilli. And in the colon is more of bacteroids and bifidobacterium, clostridium, and enterococci are seen in the colon. In between, there are other types of bacteria there. It's only for you to understand. And some reason, if these bacteria, like in colon, the bacteria increases in number, like clostridium, they can cause C. difficile, clostridium difficile overgrowth, and that can cause pseudomonas colitis. Well, IBS and SIBO, the various theories again, look at the secretory, salivary, hemoglobin A, and also the gastric acid. Low acid can cause it facilitates development of more bacteria in the small intestine and duodenal bile, and also abnormal oral GI motility. Excess GI motility can be there, and also some factors like female gender, old age. These things they can have more symptoms of SIBO along with IBS. Well, coming back to the treatment of small intestinal bacterial overgrowth, the treatment in this category is antibiotics. When I talk about antibiotics, we don't give routine antibiotics. This is an absolute no, and I don't recommend at all. This is something called rifaximin. It's like a relatively new antibiotic, not exactly new. In the last 5-6 years, we're using it more often. The rifaximin is a simple antibiotic. Usually, hardly it gets absorbed from the GI tract. And the dosage I given you, 3 to 4 capsules a day for 7 to 10 days. And along with this, probably if you add probiotics, like which contains lactobacillus, Saccharomyces boulardii, and these things, they might help in replenishing the bacterial population. They will decrease in the symptoms of SIBO. And dietary modification, and a few diets increases the development of this excessive gas production. So they are important. And prokinetics, yes, they do help in some patients of SIBO, particularly with IBS. And rarely, we also can look at the fecal microbiota transplantation. For SIBO and IBS, it was never done. At least I never heard about anybody getting it done. But this fecal microbiota transplantation is done in some advanced or difficult cases of ulcerative colitis. Important point, take-home message for you is, in case of IBS, if the patient also has a bloating and if you suspect small intestinal bacterial overgrowth, SIBO, they do get a lot of improvement when you take care of the SIBO. That means rifaximin and probiotic might help a lot in this subcategory of IBS patients with SIBO. And other thing is, all of us know this. Routine practice, most of these IBS patients, they also do complain of a lot of psychiatry problems and anxiety disorders. So if you look at the number of patients, various trials, the diagnosis rate of psychiatric disorders in treatment-seeking IBS patients, it is almost 50% to almost everybody of IBS patient, maybe having some or other kind of psychiatric disorder. And all may not be very significant disorders, but they do have some kind of background problem of psychiatric disorder. And in this, the anxiety is much more common psychiatric comorbidity with the IBS, and at least 2/3 of patients of IBS must be having this anxiety. Pathophysiology, probably I think I'll not spend too much on this, but I just want to show genetics, environment, life stress, psychological state, and coping with the stress, social support, all of these things, they do matter when they have this problem. And the brain-gut axis, already we discussed about it. And so that, and along with that, some disturbance in the motility, sensation of the abdominal, the intestinal wall, inflammation, altered microflora, food and diet, all these things, they do contribute to the development of IBS. And for this, the medications, healthcare visits, daily counseling, and that might improve quality of life. The brain-gut axis, multi-level dysregulation of the intestinal system interactions. The one point I would like to say is, they do play an important part in the development of IBS in those patients of IBS. Well, so when we talk about IBS and anxiety, there are some drugs which we routinely use. There can be antidepressants, benzodiazepines, or typical antipsychotics like quetiapine. All these drugs we use in the management of IBS as per the patient's need, and more of symptom-based approach. So when you look at the treatment of IBS, the first thing is dietary modification, low fat FODMAP diet. I'll talk to you about that FODMAP. And the other one is avoid gas-producing food like cabbage. And the important thing is, if patient says so-and-so food is giving trouble to them, causing a lot of gas, probably I think it makes sense. It's obvious that they should avoid that kind of food for some time and restart again. Then the patient will understand which foods are suiting them, which foods are not suiting them. And the gluten-free diet do help in some patients of IBS. Gluten-free diet normally we give for celiac disease, but in some patients of IBS, they also will be useful. And also lactose-free diet, because some of the patients may have lactose deficiency. Lactose-free diet may be useful in some patients of IBS. Increased fiber is important. And the important point, take-home message for you here is that soluble fiber is more important for the management of IBS rather than the insoluble fiber. Insoluble fiber, in fact, it increases the bloating and worsens the pain. And other one is lifestyle modification, which I put in a big font, which probably I think even doctors, we also do not follow it that religiously. One is exercise and proper sleep. They do help a lot in the management of IBS. Coming to psychological therapy, cognitive behavioral therapy, gut-directed hypnotherapy, relaxation therapy, multi-component therapy, they're useful. Coming to the drugs for IBS constipation type, drugs for IBS diarrhea type, and drugs for pain, and drugs for associated anxiety, depression. I already covered the anxiety part, and let's see other things. FODMAPs. FODMAP is nothing but the first letter in this thing. That's fermentable. Oligosaccharides like fructose and galactose, disaccharides like lactose, monosaccharides, fructose, and polyols. That is FODMAP. High FODMAP fruits, apples, apricots, cherries, figs, mangoes, and nectarines, peaches, pears, plums, and watermelon. Low FODMAP fruits are unripe bananas, low FODMAP blueberries, kiwis, lime, mandarins, papaya, and pineapple, which we take regularly. And if you look at the high FODMAP versus low FODMAP, vegetables, there's a list like onion, garlic, asparagus, and cauliflower, mushrooms. They worsen the problem. Low FODMAP, and in this carrots, eggplants, bell peppers, lettuce, cucumber, tomato, potato, and zucchini. And the fruits, watermelon, apples, and mangoes, they are high FODMAP. And the grapes, oranges, strawberries, and pineapple are low FODMAP. And in the dairy-wise, cow's milk and evaporated milk, soy milk, cottage cheese, and ice cream are high FODMAP. And almond, coconut milk, hard cheese, butter, lactose-free, they are low FODMAP. We are interested on the low FODMAP for the management of IBS. And the protein-wise, legumes, processed meat, and marinated meats, they are high FODMAP. And in our category, eggs, tofu, and non-marinated meats, fish, chicken, they are low FODMAP. And the cereals-wise, wheat, rye, barley, these things have a high FODMAP. And oats, quinoa, and kora, these things are less FODMAP. Sugars, high fructose and honey, they are high FODMAP. And maple syrup and table sugar are low FODMAP. And nuts and seeds, like cashews and pistachios, are high FODMAP. And probably in IBS people, they have to take more of peanuts, pumpkin seeds, and walnuts. The problem with low FODMAP are there's a reduced intake of fiber, calcium, iron, zinc, vitamin B, and folic acid, and natural antioxidants. So keep a check on this. And drugs in IBS, I think I have to finish in another 5 minutes or so. In this IBS mixed category, we can try these drugs like serotogenic and adrenergic receptors, which influence the intestinal flora. And the drugs these are not available routinely, but the probiotics are available routinely. In the IBS D category, diarrhea category, in this more of a isin and mevarin, which decreases the pain, they're useful. And also in the diarrhea category, probably should try even sometimes we use loperamide also in most of the patients. And the other interest is lubiprostone is useful in case of constipation type, and also metoclopramide, domperidone, and centiperid are useful in the IBS constipation type. It's basically a prokinase drug which helps. And the diarrhea type, decrease the diarrhea, that is loperamide and lubiprostone. Important thing is, before you use these drugs, make sure you talk about IBS. Suppose if for infected diarrhea, if you use, let's say, loperamide, it increases contact time for the bacteria in the intestinal wall, thereby worsening the clinical condition. So that's very important. Antispasmodics, yes. So almost all the major societies, they do recommend antispasmodics as part of IBS management. and problem manage, because pain is going to hurt anyone. So IBS person with pain, it's important for us to take care of the pain, and because it gives a prompt symptom relief, thereby adherence will be much better. Antispasmodics, anticholinergics block muscarinic receptors. In this, dicyclamine, clindamycin are there. Calcium blockers are useful, like peppermint oil and also pinavarine. And a sodium channel blocker, mevarin, is very useful. And in most of the people use this mevarin in their routine practice. And also, they decrease GI spasticity and motility. In IBS, the antispasmodics help in improvement of the abdominal pain, global assessment of IBS symptoms, and also IBS symptom score. So if patient requires something like antispasmodic, please use it at the earliest. Well, the mevarin is a drug which is routinely used for the management of IBS. I'll not go much through the thing, but already we discussed most of these things. So I think I'll try to conclude my talk saying that symptom-based criteria for diagnosis is important, where you don't require any big investigation to make a diagnosis of IBS. Is IBS more of a good history taking by the clinician? That's very important, and an acumen to rule out a red flag sign. That's all you make a diagnosis of IBS. And in the symptom-based one, abdominal pain or discomfort, relief with the defecation, and change in consistency or frequent stool is important to make a diagnosis of IBS. And alarm symptoms, keep a check, and anything is there, investigate the patient thoroughly and do the necessary investigations. Generally, we do CBP and sigmoidoscopy in most of the patients. And any alarm symptom and abnormal lab, the patient requires a full set of investigations and review the patient within 6 weeks. And therapy is directed to alleviate symptoms, and all the drugs which I said, almost all of you are using it in our routine practice, and establishing therapeutic relationship with the patient. And more of a good counseling is spend a little more time with the IBS patient, and most of the times these small medicines, they do a wonderful job for the patient to take care of the symptoms. And the treatment has to be individualized. There's nothing like IBSD, use this drug. It's not like that. Depending on the patient's various things in the IBS, there can be anxiety, that can be stool, that can be bloating in the tummy. So there's a treatment plan for each patient. And choice of treatment, you always take care of the predominant symptom first. The patient says, I have problem with the stool, take care of the stool problem first. That can be diarrhea or a constipation, and also severe disorder and comorbidities, and also the preference both from the patient point of view and the clinician point of view. And I think I skipped this here. Thank you very much. I think I took almost 29 minutes. And any questions are there, I'll be happy to take. And or any if someone wants to give an opinion on this topic, you're welcome. Thank you very much. Hello.
Thank you so much, sir, for your comprehensive talk and for such wonderful insights that you have shared upon the topic. Thank you so much for that. We have received 2 questions, sir, and I would like to put it across to you. The first question is, what is the cause of abdominal bloating, which is often a symptom in patients with irritable bowel syndrome?
Yes, again, I was trying to see you, so I missed it. Can you repeat again?
The question is, the question is, what is the cause of abdominal bloating, which is often a symptom in patients with irritable bowel syndrome?
Well, the bloating in the IBS, that can be mostly because of, one is the diet, and some of the dietary products can cause more gas. The second one is SIBO, spontaneous bacterial overgrowth. So you need to look into these 2 categories and give an appropriate medication. And the prokinetics usually help the patient. Yeah.
Thank you so much for answering this question. We'll move to the next question. And the question is, when is colonoscopy indicated in the diagnosis of irritable bowel syndrome?
We never do colonoscopy to make a diagnosis of IBS. We'll never do it. But any red flag sign, elderly age group, recent onset of symptoms in the elderly age group, or blood in the stool, or unintentional weight loss, then they do require a colonoscopy. important.
Thank you so much sir, for answering this question. We'll move to the next question, and the question is, what are possible infection-related causes of IBS?
What is it possible?
Infections related to the causes of IBS.
Once you say a significant infection, when you say significant infection, then IBS diagnosis is out. Like if you talk about Clostridium difficile, C. difficile in colon, you can't say IBS. Having said that, some of these bacteria, like you were talking about bacterial overgrowth, that can cause some of the symptoms of IBS, particularly bloating point of view. But as an IBS, infection has no role in case of the diagnosis or management of IBS. As a cofactor, yes.
Thank you so much sir, for answering this question. We'll move to the next question that we have received. And the question is, what symptoms are inconsistent with IBS and suggest an alternative diagnosis?
Well, the red flag signs. So that means somebody has a blood in the stool, nighttime diarrhea, weight loss, anemia. That definitely you need to go for the investigation. It's no more IBS. Or rule out other things before you say IBS.
Thank you so much, sir, for answering the question. That was the last question for today's session. And at the outset, I would also like to thank all the viewers who have joined our platform for the better exchange of knowledge that has been shared by you. And I hope that your knowledge will be helping them in their daily clinical practices. So thank you so much, sir. Thank you for your valuable time and for being here at our platform.
Thank you much. You're welcome.
With all your last comments, sir, we can conclude the session here for today.
Sure. Bye-bye.
Thank you, sir.